Start. Pa.
A very good evening to one and all present here. I welcome you all to the Medusane Forum. It gives me immense pleasure to introduce Medusane, a platform that has rapidly grown to become a trusted education partner for multiple students across India. Our mission is simple to provide accessible, high quality educational resources that empower students to excel in their academic and professional journeys. With a vibrant community of over 23,000 YouTubers, Medicine has made a significant impact in areas like clinical case presentation, theory lectures, MCQ discussions, career guidance, and skill development. We are constantly evolving to meet the needs of our students, whether they are preparing for competitive exams or seeking to build strong career foundation in medical practice. One of the things that make medicine stand out is our commitment to mentorship. While there are numerous platforms offering medical education, medicine uniquely emphasizes personalized mentorship. We aim to provide students with daily guidance, one to one support, and practical insights that go beyond textbooks, helping them build confidence and clarity on their career path. Having said this, let's dive into today's topic. That is World Diabetes Day. We are reminded of the importance of awareness, education, and collective efforts in combating one of the world's most pressing health challenges, diabetes. This year, we are excited to present a special lecture series dedicated to deepening our understanding of diabetes from its physiological and biochemical foundations to its management and complications. World Diabetes Day is more than just a date on the calendar. It's a global call for action. Diabetes affects millions of lives, impacting not only the patients, but also their families and communities. Through this series, our goal is to bring together experts in the field to share valuable insights that will empower healthcare education professionals and students and the broader community to tackle diabetes more effectively in daily practice. Each session is designed to address crucial topics from the basis of insulin function to advanced management strategies, along with the latest guidelines. This initiative emphasizes the role of continuous learning and collaboration in addressing diabetes and aims to equip with practical knowledge and skills that are essential for improving patient care. We believe that raising awareness and fostering understanding of diabetes is vital in reducing its burden in the society. We are grateful to our distinguished speakers and enthusiastic participants for being part of this mission. Together, let's make this World Diabetes Day a step forward in our journey towards a healthier, diabetes aware world. Having said this, I would like to welcome our very own founder of this platform, Medusane, Dr. Raghunandan, who has been the man behind this event and the mind behind its success. I welcome you, sir. Over to you.
Thank you, Mantra, and thank you, ma'am, for joining with us today. I think we are in the third day of the series, and today is the World Diabetes Day, and I think it's very fortunate to have our own faculty, our own mentor of our Medusane platform, Dr. Rashmi, ma'am, with us today. And I think in the last 2 days, we were seeing about the basics and the foundation, which are very crucial to understand the further management strategies. Today's topic, it is very crucial to understand the one of the global challenges with regards to the complications of diabetes, that is diabetic kidney disease. And protecting the renal health in diabetes is a foremost goal for any practitioner. And I think today we will be gaining not only the knowledge but strengthen our clinical perspectives and also importance of the early interventions with regards to the diabetic kidney disease. We are very much honored to have you here, ma'am. Thank you so much. And thank you once again, the team Medusane, as well as all the members, those who are doing their extraordinary work here and supporting, not as she told, it is not just one man's work here, but a team's work. And I think I have to thank everyone. So it's your day, ma'am, and thank you so much for joining with us today. And I would request our today's host to introduce the speaker of the day, then hand over the session to you. Thank you, ma'am.
Having said this, Dr. Rashmi Shivaram, she has done her MBBS in Savita Medical College and Hospitals, Tandalam, Kanjipur. She has done her internal medicine DNB in Sundaram Medical Foundation. Currently, she is pursuing DNB in nephrology. Over to you, ma'am.
Thank you so much for the nice intro. So I'll just share my screen. It's always a pleasure to come here on Medusane. 1 second. So on this occasion of the World Diabetes Day, so I think diabetic nephropathy is among the leading causes of end-stage renal disease, as you must all be aware by now. And it plays a very important role. The primary care physician has a lot of role to play in this. So I'll be very happy if all of you can spend your time and listen to this very keenly. So there are a lot of things that primary care physician can do before you refer the patient to the nephrologist. Of course, a nephrologist must follow up the patient, but still there are some things which you can do on the aspects of glycemic control as well as preventing diabetic kidney disease in your diabetes population. So it's very important for all of us to be aware of this because it's not rocket science, it's very logical. So we must try to understand the basics, the mechanism, and then we'll just go forward. Okay. I think a little bit of the basics must have been covered yesterday in Dr. Jamuna's talk. So the histopathology she has covered, but still I'll just touch upon a few points in that. Okay, so let's start. So first of all, diabetes type 1 and type 2 diabetes we have. So what happens is, we already know the pathophysiology of the type 1 and type 2 diabetes patients. So when the patients present to us with diabetic kidney disease, when do we label the patient as having a diabetic kidney disease? That's when the patient is having a proteinuria, albuminuria especially. Okay, an albuminuria of more than 2.5 grams. Okay, and the creatinine level is increasing or there is a decrease in GFR. That is when we label the patient as having a diabetic kidney disease. Okay, so when does this happen for type 1 diabetics or type 2 diabetics? So for type 1 diabetics, they need to have a long duration of diabetes before they get diabetic kidney disease. It is also related to the control of hyperglycemia as well as the duration. Both factors play a very important role when it comes to the development of diabetic kidney disease. The other point, when we look at in type 2 diabetes mellitus, this type 2 diabetes goes undetected or undiagnosed for a very long period before they actually present to the doctor. Okay, so when should you start screening these patients? So after the patient is diagnosed with type 1 diabetes, 5 years after that, you should start screening the patient for diabetic kidney disease. Whereas for a patient with type 2 diabetes, at the start of diagnosis, as soon as you diagnose the patient as having diabetes, you should start screening the patient for diabetic kidney disease. Okay, so this is the major difference that you need to understand because of the different pathophysiology behind how type 1 and type 2 diabetes develops. Okay, so type 1 diabetes will be after 5 years of development of type 1 diabetes, and type 2 diabetes will be at the start of diagnosis. As soon as you diagnose type 1 diabetes, type 2 diabetes, you have to start the patient screening. So how do you screen? You need to look for the creatinine levels as well as the urine albumin excretion. So you look at the urine protein creatinine ratio or the urine albumin creatinine ratio. Based on that, you can stage them. You can find out if they're having CKD, if they're starting to progress into CKD, are they having diabetic kidney disease also or not? But you must remember one thing. If a diabetic patient presents to you with some kidney issue, with some renal dysfunction, say the creatinine is increasing, you must not just close your diagnosis with diabetic nephropathy. You need to first make sure that the other diagnoses are not there. A patient with diabetes can present with glomerulonephritis. A patient with diabetes can present with any renal infection. So you must have an open mind before you close the diagnosis with diabetic nephropathy. Okay, so I'll make it clear as in when we say that it is diabetic nephropathy and when we don't say that it is diabetic nephropathy. We'll just go into the details. Okay, so before we go into that, I would like to again emphasize the physiology, pathophysiology behind the diabetic kidney disease. So everything is inflammation. Diabetes is an inflammatory disorder. Okay, so this inflammation keeps on happening. So what happens in the end? You will get diabetic kidney disease. So the diabetic system, there is hyperglycemia. Okay, so diabetes doesn't come separately. When the patient is diabetic, other metabolic problems also come along with that, like hypertension, obesity, all the other things come. The metabolic syndrome, especially along with hyperglycemia, what happens is it triggers the inflammatory pathways. Okay, lot of cytokines are involved, lot of mediators are involved. So what happens is once the inflammation starts happening, what does the body do? The body will try to clear the inflammation. when the clearing of inflammation doesn't happen effectively, and over time, what happens? Scarring of the tissue happens. This is what always happens. When the repair goes on and it is not effective, what happens? It repairs by scar tissue, isn't it? That's what we see in all the inflammations. So this scar tissue will later develop, and that's what we see as the nodules and the interstitial fibrosis, which you must have seen yesterday. Okay, so let me just put it brief. The first point, you can concentrate on this. There are factors in the diabetic milieu which induce systemic microinflammation. This microinflammation, what happens? It triggers the inflammatory pathways in the kidney, and there are a lot of mediators released. Okay, so a lot of mediators, I mean the interleukins, cytokines, all those things are released. Okay, because of that, what happens? One thing you must remember is this TGF beta. This TGF beta is what is important in actually causing the CKD progression. Okay, so this TGF beta, we'll come to that later. Okay, then what happens? Immune cells are recruited for repairing the damaged cells and tissues within the kidney. Immune cells, when we talk about this, for diabetic kidney disease, the immune cell which is most important is macrophage. Okay, the immune cell which is most important is macrophage. Macrophage infiltration happens. It tries to clear the inflammation. It tries to repair the damage within the kidney tissue. But what happens? The unresolved inflammation results in more inflammatory triggers. More and more inflammation happens. Heat shock proteins are elevated. Reactive oxygen species happen. So all these things will go and damage the endothelium. Okay, all these will go and damage the endothelium. It will also affect the blood vessel. Blood vessel will start thickening. There will be fibrosis. There will be scarring. You can see there will be glomerulosclerosis. Sclerosis is nothing but dead tissue. And mesangial expansion will happen. There will be podocyte injury and basement membrane thickening. All these things will happen inside the diabetic kidney. Okay. So now let's see a healthy glomerulus. I'll just label the parts for you. So this is the capillary. Okay. And this is the Bowman space. This is the Bowman capsule. And this is the Bowman space. This is where the urine is formed. This is the afferent arteriole and this is the efferent arteriole. So what happens? The blood flows from here. It comes here. It is filtered in the glomerulus. And then the urine comes out this way. And then later it goes on to the tubule. This is what happens, isn't it? So in a diabetic kidney, what happens is, you can also note one more thing. These are the podocytes. Okay. Often you hear this term of hyperfiltration injury. I'm sure all of you would have heard this word of hyperfiltration injury when it comes to diabetic kidney disease, especially. So this the hyperfiltration is what happens. This urine, when it's being produced, it comes out of this space. So what in hyperfiltration, what happens is the GFR of a single nephron becomes high. Okay, every GFR, if suppose a single nephron is producing X amount of GFR, in hyperfiltration, the X amount will increase. Okay, so as the urine increases, as the production of urine increases, this podocyte will start getting detached. It will start getting detached, and therefore the podocyte loss will be there. Okay, see here you can see it is touching it is almost in approximation with the capillary wall. But what happens later? It will start moving away from the glomerular filtration barrier and the podocyte loss will be there. Okay, so diabetic kidney disease is also a type of podocytopathy. It is also a type of podocytopathy. Okay, there are multiple mechanisms happening. One of the mechanism is because of the podocytes. Okay, so what happens in a diabetic glomerulus? You can see the arteriole, there is arteriolar hyalinosis. Okay, then there is mesangial deposition. You have mesangial nodule formation, right? The glomerular basement membrane thickening will be there. Podocyte hypertrophy and the podocyte effacement will be there. The interstitial fibrosis in the interstitium, tubular atrophy will be there. Okay, all this will happen. But one thing you should notice is the afferent arteriole will dilate and the efferent arteriole will constrict. Okay, these are all seen in the diabetic glomerulus. So I told you, like, we cannot label all patients with diabetes with a kidney problem as having diabetic nephropathy. Okay, so when do we say that the patient is not having diabetic kidney disease and we should look into why this patient is having a kidney problem? Suppose the duration of diabetes is very short. If it is less than 5 years, if there is a rapid progression of kidney function. So what happens in diabetes is the decline in GFR is very slow in typical patients, but it's not always true. Most of the time, the decline in GFR is very slow. But if you notice that today the patient is coming to you with 2 creatinine, then tomorrow in 2 days is coming to you with 3, then next 2 days it's 5, and then he ends up on dialysis. That kind of fast progression is not usually seen in diabetic nephropathy. Okay, though it can be there, it is not usually seen. Okay. Then microscopic hematuria. Diabetic kidney disease produces proteinuria but not hematuria. Then abnormal serology is suggestive of another glomerular lesion. Like you have vasculitis, you have ANCA positivity, or you have ANA positivity, or you have an anti-GBM positivity. So all those things means that there is no diabetic nephropathy. They may have a background of diabetic nephropathy, I don't deny, but still they could develop some other lesions also, which you must have an open mind towards. Then if there is no proteinuria, then you cannot label the patient as having diabetic nephropathy. And the absence of other microvascular complications, like the patient is not having retinopathy. Though retinopathy in type 1 diabetics, you say that it is very sure. If the patient is having retinopathy, then they definitely will have nephropathy. But in type 2 diabetics, it is not, the association is not so clear. But still, there will be some evidence of a microvascular inflammation in other places, like a peripheral vascular disease. You must have an open mind towards that. So, when the patient is having a short duration of diabetes, rapid progression of kidney dysfunction, microscopic hematuria, presence of other serology positivities, absence of proteinuria, or absence of retinopathy or other complications, in these cases, we need to biopsy the patient. Okay. Essentially, diabetic kidney disease is a clinical diagnosis. For diagnosing a patient with diabetic kidney disease, you don't have to biopsy the patient. But in such cases, in these indications, you have to biopsy the patient and find out. So in a diabetic kidney disease, when you biopsy, what will you find? You will find, like already told you yesterday, these are Kimmelstein-Wilson lesions, Kimmelstein-Wilson nodules. You can see mesangial hypertrophy is happening here. Mesangial expansion is there, and there is a nodule here, right? And this is something which is called a capsular drop. This is a capsular drop. This is also a lesion seen in diabetic nephropathy. Apart from this, you will see the basement membrane is thickened. You can see the basement membrane is thickened. You will also have interstitial fibrosis and tubular atrophy. Okay. Yes. So the histopathological classification, the grade 1 will be mild or non-specific light microscopic changes. They can have some mild food process effacement and GBM thickening. The second will be mild mesangial expansion. 2B will be severe mesangial expansion. Grade 3 will be nodular sclerosis, which has the characteristic nodules in the mesangium, which is Kimmelstein-Wilson lesions. And grade 4 is advanced diabetic glomerular sclerosis. Okay. So based on these stages, you can also see how they progress towards end-stage renal disease. Okay, so coming to how they present, you have 5 stages again in this presentation. So the first thing, like I told you, hyperfiltration. We know the differential diagnosis for an enlarged kidney. Usually we say two, one is diabetes, the other one is HIV. Okay, so diabetes, the increased renal size is because every single nephron is increased in size. Okay, because of the increased enlargement in size, the kidney size also becomes more. This hyperfiltration, increased renal size, and normal albumin excretion. You don't have proteinuria in that stage. It's only hyperfiltration. In the second stage, what happens? There will be small microalbumin, which is getting secreted, small amounts. The stage 3, microalbuminuria. When do you say it's microalbuminuria? Albumin creatine ratio between 2.5 milligrams per millimoles, okay, per 24 hours, which is 30 to 300 milligrams per 24 hours per day. Okay, when you say overt proteinuria is when they have more than 300 milligrams in 24 hours. Okay, and the end-stage renal disease, we know they have to end up on dialysis, advanced glomerulopathy, and the GFR declines. Okay, there is a chance that the microalbuminuria, if you treat effectively at this stage, if the patient is presenting to you in this stage and you treat them well, there is a chance that they can go back. The changes can go back to normal albuminuria. The hyperfiltration can be reduced. If you do certain things, the hyperfiltration can be reduced and you can actually prevent the progression of diabetic kidney disease. Okay, so this is very important for all of us to know. So, like any other metabolic disease, it has a very holistic approach that is needed for the patient. We have lifestyle management, first-line drug therapy. We have to look at the protection of the kidney as well as the cardiovascular outcomes, and the additional risk factors should also be controlled. Okay, so let's see each one by one. Okay, so first thing, when a patient comes to you, you start the patient with diabetes, you start the patient on metformin. That's the first drug we are supposed to start on, right? So as soon as you start the patient on metformin, you will start screening them for diabetic nephropathy. And you notice that they are developing proteinuria. So as soon as they start developing proteinuria, you should start the patient on AC inhibitor or ARB. Okay, AC inhibitor or ARB. There are multiple studies which have been done and which have proven that ARB is very effective in reducing the proteinuria as well as reducing the hyperfiltration injury and also providing antihypertensive control in these patients, Okay, So as we all know, once you start an ACE inhibitor or ARB, what should you check? You should look for the serum creatinine and potassium within 2 to 4 weeks. Okay. If the patient is having a normokalemia, you can either, if needed, you can increase the dose if the proteinuria is not coming under control, or you can actually continue the same dose if the proteinuria is well under control. When you say normokalemia, and the creatinine increase should be less than 30%. Okay. Suppose the patient is having hyperkalemia, what should you do? Instead of stopping the drug, you should actually try to give potassium binders, sodium bicarbonate, you should give diuretics, and try to control by other means, control the potassium by other means by decreasing the intake. All these things you should be doing. You should see if some other drug is also contributing to the potassium. So you should try to modify the other things before you actually stop the AC inhibitors or ARBs, because the benefit of the AC inhibitors or ARBs is well justified. Okay. Suppose the creatinine increases more than 30%, then you should actually see whether they are volume depleted, whether they have any other AKI, and you should actually consider the diagnosis of renal artery stenosis. If the increase in creatinine is more than 30%. If there is renal artery stenosis, then that's an absolute indication to stop. Okay. So if the hyperkalemia is not getting controlled, even by doing all these things, or if the creatinine increase is more than 30%, then you can consider stopping the AC inhibitors or ARBs. Otherwise, you should continue. If the creatinine is less than 30% increase, and if there is normal potassium, and if you can control the increase in potassium with other potassium binders or decreasing the potassium intake, then you should continue AC inhibitors or ARBs. Okay, like I told you, there are a lot of trials which is not needed. I mean, like you need to just be aware of the names, like the renal trial for the AC inhibitors, renal trial for the AC inhibitors or ARBs, then for the SGLT2 inhibitors, which will come EMPA-REG, then DAPA-CKD. Okay, all these trials, Credence trial, all these trials are named trials which have given very good benefits, which have shown very good benefits in cardiovascular outcomes as well as renal outcomes. Okay, so the patient has come here, you're giving him glycemic control as well as you're giving him an AC in ARB. So what is the next step? This is now the talk of the town, which is SGLT2 inhibitor. What does this SGLT2 inhibitor do actually? SGLT2 inhibitor is empagliflozin, dapagliflozin, all these things, canagliflozin. So nowadays we don't use canagliflozin, we use dapagliflozin mostly. So patients with diabetes, CKD, a GFR of more than 20 ml per minute, if the patient is already on metformin and AC inhibitor, the next thing is we have to start them on an SGLT2 inhibitor. So what it does, it also gives some glycemic control, right? It also gives us some glycemic control. But apart from that, what it does is, so in the kidney, it's a sodium glucose transporter, right? So when the patient is having hyperglycemia, what happens is a lot of sodium should be excreted. This sodium glucose transporter should be inhibited. So when this sodium glucose transporter is inhibited in the tubule, proximal tubule, what happens? Lot of sodium and glucose will be coming out in the urine. Because this is coming out, the sodium and glucose, what will happen is this will travel along and come to the distal tubule. When there is a lot of sodium in the distal tubule, the tubular-glomerular feedback will be affected. So the hyperfiltration or the GFR, the renal blood flow will reduce. Because of the tubular-glomerular feedback, the blood flow to the kidney will reduce, and thereby the hyperfiltration can be reduced. So that is a mechanism behind this SGLT2 inhibitor. So what happens? It tries to excrete lot of sodium as well as glucose. Because of that, the hyperglycemia is reduced, and it also protects the kidney by reducing the hyperfiltration. Okay. So, but what is the side effect of this? I think all of you must be aware of this. There's a lot of genital infection, especially fungal infections in women. Men also it can happen, but it is more common among the women. And it can also cause euglycemic ketoacidosis. So these are the two indications where you should reconsider. But this is a very, very effective drug, and you should have the volume status. So because a lot of sodium and glucose is getting lost in the urine, you should always maintain good hydration of the patient, because they will tend to get dehydrated. You should maintain good hydration, give the patient an AC inhibitor or ARB, metformin, as well as an SGLT2 inhibitor. Okay, like I told you, what is all improved by the SGLT2 inhibitor? Hyperglycemia is better, hypertension, the tubular-glomerular feedback will be better. So it helps in inflammation, reducing the inflammation, hypoxia, and fibrosis. Okay. Yes. So the next thing after SGLT2 inhibitors, the other talk of the town is non-steroidal mineralocorticoid receptor antagonist. So MRA, non-steroidal mineralocorticoid receptor antagonist. So that is Finrenone. Okay, Finrenone. So now you have started the patient on AC inhibitor, metformin, AC inhibitor, ARB, SGLT2 inhibitor, and then even then if the proteinuria is not getting controlled, you can add Finrenone. Okay, this is also similar to the SGLT2 inhibitor. It has a very good renoprotective effect. Okay, and also a cardioprotective effect. This is used for patients with recurrent cardiac failure also. Recurrent congestive heart failure, those patients who are present with that, we give this Finrenone. It acts very well. But one thing you must be careful is the potassium concentration. Like the ACE inhibitor or ARB, this also has a tendency to increase the potassium. So we start at a dose of 10 milligram, you can increase up to 20 milligrams. You have to monitor the potassium and then you have to correct it. Okay? Yeah. So how do we monitor the glycemic control and the targets? So as in all other patients, HbA1c is a good method of actually using it for a glycemic control measurement. Okay. So how many times should you check it in a patient with CKD? At least twice per year. If the sugars are not being controlled well, then at least 4 times per year. So you have to do it frequently and alter the medications. Okay. And the target should not be, it should be around 7%. So when the patients develop CKD and as the CKD worsens, they have a tendency towards hypoglycemia. So you will see when the patients very strong diabetic patients who are requiring so much of insulin, so many medications, once they become end-stage dialysis patient, when end-stage kidney disease patients on dialysis, they will not require so much of insulin or so many drugs. Okay, that is because they have a tendency for hypoglycemia. Okay, so you should keep the target around 7. It should not be very strict, like 6.5, that's not advisable. You should maintain it around 7. But the other problem is you cannot use HbA1c as the CKD progresses because the anemia will be there. This HbA1c is based on the Hb, hemoglobin. So as the CKD worsens, the anemia component increases. So then it becomes less reliable. Okay. So till that time, you can actually use HbA1c. Okay. So if the CKD stage G1 to G3B twice per year, and if up to 4 times per year, if you're not achieving target or if there is a change in therapy. Okay. Yes. So coming to the dietary recommendations. So whatever recommendations I'm telling you is based on the KDIGO guidelines. It's based on the KDIGO guidelines. So dietary recommendations, all of us know, whether you're eating, whether you're in Indian or elsewhere, whatever your diet is, you should have lots of fruits and vegetables, right? You should have lots of fruits and vegetables. At least half of the plate should be fruits and vegetables. The other half should be divided between some amount of protein and some amount of carbohydrates, right? You need carbohydrates also, you need correct amount of proteins also. So what is the protein requirement that we suggest for the patients? So if the patient is not on dialysis, we usually suggest a lesser amount of protein, 0.8 kg, 0.8 gram per kg per day. If the patient is undergoing dialysis, then we tell the patient to have a slightly higher diet, which is 1 to 1.2 gram per kg per day of protein. And we usually encourage intake of lot of plant proteins. Animal proteins, we generally ask them to take lesser because of the hyperuricemia, which is also possible. Okay, so we usually encourage lot of plant protein like channa, all the pulses, paneer, all these things we advise the patient to take. When they're on dialysis, we ensure they have high protein diet so that their muscle mass can be maintained and their weight can also be maintained. Okay, so here are some examples of animal proteins and plant proteins. So coming to the salt. So salt intake should be slightly lesser. But if you are using a SGLT2 inhibitor and the patient is having lot of dehydration, you should make sure that the appropriate amount of salt and water is actually going in. There is no specific renal diet. So if you see in hospitals, they will give a generalized, if you are having a creatinine increase, they will say that you should have a renal diet. You should restrict the sodium and water, everything you should restrict. It's not like that. It's only based on the edema and hydration status of the patient decides whether you should take sodium, salt or water. Okay. So it's based on that we should be deciding. It's not based on the creatinine level. Okay. So, but you should not eat lots of sodium, lots of like pickles and all those things you should avoid. Extra salt you should avoid, but you should take the minimum amount of salt which is needed. Okay. Should be less than 2 grams of sodium per day or less than 5 grams of sodium chloride. So the decreased sodium intake, what will happen? It will also improve the blood pressure. So all these things, this metabolic syndrome can be controlled if you have a moderation in the salt intake. I would say moderation and not a decrease. Okay. It should be a moderation. So how to cut out salt? You should avoid the processed foods. Basically, you should eat fresh. Okay. You should avoid high foods with, all the processed foods or all the stored foods. have lots of sodium to increase the shelf life, they increase the sodium content. So all those things you can avoid. You can avoid sauces. You can avoid all this appam and papadams. All these things you can avoid, right? Yes. So coming to the lifestyle interventions. So lifestyle, I already told you about the diet. Next, what about exercise? You need to have at least physical activity, good moderate intensity physical activity for at least 150 minutes per week. So what happens is once the patient come into CKD, the anemia will start progressing and they will say that I'm very tired, I don't want to do these things. They will start restricting themselves. But in fact, if you have a better quality of life, if you keep on, you do the appropriate physical activity, then the quality of life will be maintained as well as your blood parameters. Your sugars will be under control, your hypertension will be under control, your CKD can be controlled because the progression can be controlled. Okay, because you're modifying all the modifiable factors. Once you do all these things, you encourage the patient to be more physically active, more dietary modifications are done, then you can actually see that the patient is having a very good outcome. You can actually delay the progression of diabetic kidney disease. Okay, so physical activity, nutrition plus weight loss, that is the first thing. After that, you give metformin, SGLT2 inhibitor. For the hyperglycemia, the next thing is GLP-1 receptor agonist. This is also a very, very important drug. I want to touch upon on this topic. So this GLP-1 receptor agonist is preferred because it has an additional weight loss property. It gives you weight loss also. Okay, so that is another important thing that you must remember. Okay. Yeah. So liraglutide, exenatide, liraglutide, semaglutide. Semaglutide is commonly used nowadays, even in India. The oral as well as the injection forms are used in India. But the one which does not require any dose adjustment for CKD patients is dulaglutide. Okay. So this has a very protective role on the kidney. Like SGLT2 inhibitors and findinone, this dulaglutide also has a very good renoprotective effect. And it also provides glycemic control. So these three drugs are very, very important. Then these are the newer drugs which are many trials are going on and it has shown a lot of benefit in improving the renal outcomes as well as the cardiovascular outcomes. So this common question is, when do we stop metformin? So metformin is usually stopped when the GFR comes to less than 30 ml. Or in some patients, when they are going on dialysis, that time we stop the patients on metformin. Okay, so this thing you need to start. If the patient is coming to you in an end stage, that time you don't start the patient on metformin, though that is the first line drug. We don't start the patient on metformin when they come with an end stage renal disease or when the GFR is less than 30 ml. Okay. So overall, the key objectives are what is you should encourage the patient. The patient should be very aware of what he should be doing to actually prevent all the microvascular and macrovascular complications of diabetes. You should encourage them to have a good lifestyle. They should be able to check their glycemic control. They should have a very strict control. They should be motivated from within to actually control and not progress, let the disease progress. Okay, that is our role, that is our duty for the patients to prevent their complications. So it's always a multi-system involvement. So you have a multiple doctors need to be involved. It's basically a team-based care. It's not just one person treating the patient. At the appropriate time, the patient has to be referred to the appropriate consultant. I mean, like the appropriate care physician. Like if it's a nephrologist, your nephrology problem, you have to send them to nephrologist. If it's an ophthalmological problem for retinopathy, you need to refer them to them so that point of care will be good, right? Yes. So it's a comprehensive management. So goals of care are the progression should be reduced, the cardiovascular disease risk should be reduced, and we should also focus on self-management, how the patient should be aware. The first line therapies for this will be metformin, SGLT2 inhibitors, RAS inhibitors. Then along with that, you give non-steroidal mineralocorticoid receptor antagonist, findinone, GLP-1 receptor agonist. And for preventing the other risk factors, you need to give, suppose the patient is having dyslipidemia, you should give statins. Okay. And you need to monitor the HbA1c, right? Like I already told you, at least twice a year, you need to measure and maintain. Okay. And then the lifestyle interventions, which is very, very important. The appropriate diet, appropriate protein requirement, and exercise for at least 150 minutes per week. Okay. So this is the overall thing about diabetic nephropathy. So the take-home message will be, I want all of you to be aware that this proteinuria is very, very important. And you should not just say if it's just 1+ proteinuria, you should quantify that proteinuria and actually see in what stage of CKD they are. You should measure the eGFR and keep a note of how they are progressing as and when they come for the reviews, so that you can prevent its progression. Okay, thank you so much for this opportunity, and I hope it was useful for all of you.
Thank you, ma'am. I think you have done more than justice to this topic by explaining us, right, from guiding us from the pathophysiology of diabetes to explaining the diabetic complications. Not just that, but you also taught us about the pharmacological actions, how to prevent it, and the lifestyle modifications, at what stage, what is to be done. You had answered all the questions as to how, when, what, why. I think you've done more than justice, ma'am. I think all of us would find it more than helpful. I thank you, ma'am, behalf of the Medusane platform. I now call upon Dr. Raghunandan.
Thank you, ma'am. Thank you so much. As she was telling, it was really a wonderful session, and I think more than 150 students who have joined would have got benefited out of it. And definitely, for those who have any doubt, you can post it in the comments right now, or else you can just post it out in the review or feedback form, which we will be sending you in the group, so that through that form you can ask any question, which will be answered by the faculty later. Okay, thank you once again, and thank you team for doing this wonderful job. And once again, I think I have to thank ma'am. Probably she is taking class from 2020 when we started this channel. And I think we have covered lots of sessions so far in the past 2 years, and now this particular series of discussion which we have taken it forward is mainly for making sure that those graduating out of medical school should definitely know about diabetes and its complication, as they are going to go and sit back in a OPD as a general practitioner, or they it will definitely be helpful again in the for preparing the NEET PG. Thank you, ma'am. Once again, I think we will look forward your presence in our channel for further discussions with respect to general medicine, ma'am. Thank you.
Thank you so much.
End Pantema session.